Hello, everybody, and welcome to another episode of Intellectual Calisthenics. I am Dr. Shabnam Daskar, and I'm truly honored and privileged to have as my guest today Dr. Chandrima Paul. Actually, Chandrima and I go back such a long time ago that Chandrima, I'll have a lot of difficulty calling you Dr. Paul, so I'm going to call you Chandrima here.
Thank
So
you.
we were studying in school together, but the fact is today she is not my guest because we knew each other from school. She is a very well credentialed ophthalmologist, so an eye specialist with a niche area called glaucoma. And very soon I'm going to ask Chandrima to introduce herself. She's got a PhD in ophthalmology, and Chandrima, I'll ask you to talk a little bit about your education and something very interesting. And I'll also ask you to talk about the award that you received from our former president, President Abdul Kalam. But this is not only about Chandrima and her accomplishments today. What we are going to talk about is many of you go for an eye checkup. Now I know that some of you don't go for an eye checkup unless you have problem seeing something, you have problem reading or something. But an eye checkup is actually a part of an annual health checkup, except for some certain conditions where something like diabetes, where again Chandrama will briefly talk about it a little bit. But my reason for having Chandrima as a guest here today is to make people aware of what are the different tests that you should look for and what are the ones you should ask for. And Chandrima will also explain how most of these tests will not be available in just about just your I don't know where people go for their eye checkup. Some people just go to their, their local eye frame shop, and there's an optometrist at the back who's just checking your numbers. So that is not enough for everyone. So what are the eye checkups that you should look for? Where should you ask for? But before that, over to you, Chandrima. I'll ask you to introduce yourself first.
Well, thank you very much, Shabnam. And at the outset, I'd like to say it's really an honor and privilege to be here on this show, and very, what should I say, auspicious for me, because this is my first, so to say, a talk show with a school buddy. So it's generally with professional colleagues that we do such things, but this is a unique experience, and thank you so much for
You're welcome.
inviting me for this. And a little bit about myself, in the sense that we went together to school, as Shabnam already told you, and then to the medical college where I graduated and post graduated. Following that, actually, I did my FRCS, and after that, the PhD. And in between, actually, I was at the glaucoma service of the Moorfields Eye Hospital in London. So I had a good exposure there. And apart from that, I've also been at the Doctors Harvard and Fine Center at Eugene, in that's in the west coast of the States, where also I had a huge exposure. And following that, I started my practice back in India. And initially, I before I went out, I went to Arvind for a while. So I had an exposure in glaucoma with one of the glaucoma stalwarts of India, that is Dr. Ramakrishnan. And then once I came back, I started my practice at BBI Foundation, Kolkata, as a consultant. And finally, we took over BBI Foundation in the year 2007. Yes, 2007. And now actually we have 3 hospitals in the state. And I try to take care. I generally stay at the Mother Center, which is at Minto Park, and I head the glaucoma service there. And we do have all the state-of-the-art instruments and a good glaucoma faculty at the foundation. And it's a pleasure working there. And you wanted me to talk a little bit about the award. Well, that was in 2006. I had done a research paper, which was just the best national paper in research work in glaucoma for that year, 2006. by the All India Ophthalmological Society. And that's when I was given that award. And the same year, I also won an award from the state, which was called the Dr. B.K. Mitra Award, which was again just the best paper in the state for that year. And apart from that, what I'd like to say is that we've done this study called the Hubli River Glaucoma Study, which is the largest
Chandrima, I'm going
population-based
to
prevalence
interrupt you
study.
here. I'm going to interrupt you here before you talk about the study. A lot of people may not know what glaucoma is. So will you just explain what is glaucoma before, and your Hubli River study sounds very interesting. We'll come to that.
Yes. So glaucoma is basically in layman's terms, high pressure, but it is not actually only high pressure. It has other, high pressure of the eyes. Yes. Intraocular pressure basically. But it's not limited to only intraocular pressure. You can have glaucoma with low pressure or normal pressure. It's not necessarily that you should have high pressure to have glaucoma. So it's basically a disease where the optic nerve, in very plain language, dies. And when the nerve dies, obviously you cannot see. So that is what glaucoma is. And it's a silent blinding disease because when the optic nerve cells die, we're not generally aware of what's happening. And that starts from the peripheral field of vision. So by the time it comes to the central field, it's actually late in the disease. So that's the reason why glaucoma is considered the thief of sight, because it steals vision from the periphery. And only when we realize it comes to the central vision, that's actually rather late. So that's
just a
what
little bit about,
basically.
what the terms that Chandrima is using about. So number one, when Chandrima talks about pressure, it is the eye pressure. It is not hypertension. So, and the optic nerve that she talked about, that is the main nerve of the eyes. So as she explained that, that is so important for vision. Now, what she's talking, so Chandrima, will you explain what is peripheral vision and what is central vision, and why losing central vision would be like so critical?
Yes. So as Shabnam just said, the optic nerve is the main nerve of the eye. So what happens when we're actually seeing an object, the brain actually sees the object, not your eyes. And it says, supposing I'm looking at a calendar on the wall. So the brain says that's a calendar. And then my optic nerve actually interprets that and I see it as the calendar. So that is how it works basically. And when we see something, we generally see it with central vision. So it's only the central 30 degrees, or to be more precise, the central 24 degrees, which actually we are always aware of it. If anything comes in that 24 degrees, we're going to see it. But if it's beyond that, we generally don't see it. Or if we turn our head, then in that case we can see it. But in optimum gaze, when you're looking straight, you do not see any object which is beyond 24 degrees of your vision. So the cells, the optic nerve cells, which actually start dying in glaucoma due to high pressure or due to any kind of ischemic changes, by ischemic changes is actually when there's less blood supply to your nerve, then it starts from the periphery. So that's the reason why we do not realize it, because unless something comes in your 24 degrees of from your nose to the periphery, you actually wouldn't see it. Yes. So that's the reason it's so dangerous, because it starts from the periphery, and the end disease is actually a tunnel vision, where you just have a central vision. And then even when you turn your head, you actually cannot see anything. So the first signs are generally, you find it slightly difficult driving, or when headlights fall on your eyes.
Driving.
So
sorry,
that's how it is.
First is driving. What is the second one you mentioned about? What is the second?
Well, generally what happens is that we see a rainbow halo around the light. The colors actually split up in the periphery. So that's the reason we see the rainbow halos around the light. And then there are other things like, frequent change of presbyopic glasses, because you cannot adjust to your near vision.
Okay.
So you keep on changing, thinking it's going to get better. But actually, that's where the problem lies. And
would it
after the age
also,
of 40,
sorry, Chandrima, I'm also interrupting you.
carry on,
So when you're
carry
saying
on.
that frequent change of lenses, sometimes, because we have the ability to zoom on devices or on computers and all that, would that also be one of the telltale signs? Like if you're needing to zoom more, let's say you're working on the laptop and like you zoom more than you normally do, would that also be one of the like the flags rather for people to go and
That's
get
that's
that correction?
that's absolutely an excellent question, and I think it's a real discovery because we didn't have this before. It's only in the last 10 years
Yeah,
when technology has advanced
yeah.
that we actually can zoom into something and see it. So
Hmm.
yes, that's absolutely true. You'd want to zoom in and see it more clearly. Yeah,
Thank you.
correct.
Carry on. I keep interrupting you.
Yeah, no, no. So that's it about peripheral vision.
Mhm.
And the end stage, as I said, is just a tubular vision. It's just like a tube. If you hold a tube in front of your eye, what you'd see through the tube, that's exactly how you see it. And the rest of the part is totally dark. You don't see anything
Mhm.
else, basically.
Oh, that's so. Is it that in India, glaucoma is a more common reason for, again, I'm not talking about diabetic retinopathy. Glaucoma is a more common reason for visual loss in comparison to macular degeneration, that which is more common, I think, in other countries. Is that true?
Yeah, actually, glaucoma is basically, it's a disease, it's a familial disease, it's a
Mhm.
hereditary disease.
Okay.
And in India, I suppose people are not so aware that if
Aware.
somebody in the family has
Mhm.
glaucoma,
Yeah.
parents or a sibling, they should
Yeah.
get themselves tested. That
Hmm.
is where the problem lies, I guess. And surprisingly, actually, age-related macular degeneration, as we call it today,
Hmm.
is
Yeah.
not that common in India as it
Yeah.
is in the Western world.
Yes,
Yeah,
I know.
yeah. And diabetic retinopathy, again, is also a huge, what should I say, uh, factor for blindness in India. But
Hmm.
that's again, not caring to show your
Yeah.
eyes when you're detected as being
Yeah.
a diabetic.
Yeah. I'm
So,
I'm going to come to that because that is, it is so under the radar. There are like people with diabetes in India. India is the diabetes capital of the world. But it is so shocking to find that so few of them actually go for a proper, eye checkup that is appropriate for them. It's like they just get their, numbers checked and they get a new pair of glasses, but that's not enough. So I'm coming to the testing, Chandrima. Now, before I go to the testing, one more question is: what are the, other than glaucoma being a familial condition, what other risk factors are there for glaucoma? Like who are at risk and who should be aware of what can happen?
yeah. So, those above the age of 40, but
Mm-hmm.
someone below the age of 40 also can have
Mm-hmm.
glaucoma. We have congenital and pediatric glaucoma as well.
Mm-hmm.
But in general, someone about the age of 40, someone with a high plus or minus power,
Okay.
and history of injury to the eye at some
Oh,
point of
okay.
time,
Mm-hmm.
and a history of using steroid drops in the eye.
Okay. So when you say steroid drops in the eye, is it like long-term steroid use, or would it be like is there? Do
Uh,
you have data to support how long use are we talking about?
Yeah. So, yes, it is long term steroid use, but then here another factor does have a role. That's those who are glaucomatous, they're generally steroid responders. So,
Okay.
say about 6 to 7% of the population are steroid responders. And in steroid responders, even if you use steroid for a week, the
Mhm.
pressure rises.
Oh, okay.
So generally, those who suffer from primary open-angle glaucoma are generally steroid responders.
Hmm.
So we have to be careful before we start a steroid eye drop. And even those who are not steroid responders, if they're using it for a long term, say like vernal conjunctivitis,
Hmm.
they use it every year at a particular time for say a month or two.
Hmm.
So they should be actually checked for high intraocular pressure, and also their discs should be checked for glaucoma.
Okay, I'll come to the testing. So, other than for this vernal conjunctivitis and the type of glaucoma you talked about, what else would people be using steroids for? Because many people are probably using it and are not aware. And you're talking
Yeah.
about steroid
So
drops with
number
the
one is
eyes. This is not systemic steroids.
yes.
Okay. This is not
Well,
steroids as a
systemic
tablet
steroids
or a...
also increase.
Oh, okay. So that would
Yeah,
cover a lot more people.
systemic steroids also, yes, also
Mm-hmm.
increase the intraocular pressure, but in the eye is more common or more
Okay.
often.
Okay. Okay.
Uh, so the other conditions where one could use steroids is following cataract surgery. We
Okay.
generally give steroids for at least 3 weeks. So that's when the intraocular pressure needs to be measured to
Mm-hmm.
make sure that there is no rise following the steroid therapy. Then following any kind of a red eye,
Mm-hmm.
where there is uveitis,
Mm-hmm.
iritis, or uveitis in total.
Mm-hmm.
In those also we treat with steroids. So intraocular pressure monitoring needs to be done throughout.
Mm-hmm.
And for any other systemic condition where steroids are indicated, there also you need to check uh, the pressure. And that's
That
it
is
basically. And if you have an eye injury, as I said,
yeah.
yeah.
Because Chandrima, the thing is, one of my areas of focus is autoimmune conditions, and a lot of autoimmune conditions are treated with. Now, when we are talking about systemic steroids, what we mean is you're taking steroid tablets or injections. So most commonly it is tablets. So if you are on steroid tablets, most importantly, now you're not supposed to stop the steroid tablets, but it's very important to have a proper eye checkup, the kind that Chandrima is going to describe now. Now, Chandrima, because a lot of these terms are things that, for sure most people are not familiar with, I'm going to put up a slide which shows, what tests you're talking about. And so these are the 6 tests that, so how this conversation started was, of course, quite often, I'm sure many conversations have started this way, is on a WhatsApp chat. So I'm going to post the names of these tests on the YouTube video at the bottom as well. So Chandrima, will you explain, briefly a little bit about each of these tests, and more importantly, where will people get all the tests together? And what are the things that they should be aware of? Because I know these are quite specialized testing. They'll not be available in just about any place, right?
Yeah. So we spoke about the eye pressure, but it's important that the eye pressure is checked with an instrument which is actually the gold standard for checking the eye pressure, and that's the
Mhm.
applanation tonometer. And the applanation tonometer, the readings that you get need to be corrected for the central corneal thickness, because that's the area, the central part of the cornea, where
Mhm.
the applanation tonometer actually touches and applanates or flattens your cornea to take the
Oh,
pressure.
okay.
So
So the
that's the reason you
cornea,
need to have,
sorry, Chandrima, I'm just
yeah,
interrupting you again. The
yeah, no,
cornea
no,
is
go
the
ahead, yeah,
front part of your eyes. It's the
yes,
absolutely the outer part. So that is called the cornea. Okay, go ahead.
the
Sorry.
transparent part.
Yeah.
So that's the reason you need to also measure the corneal thickness.
Mm-hmm.
And the central corneal thickness is a risk factor for glaucoma, because if
Okay.
you have a thin cornea,
Mm-hmm.
you would have a lower intraocular pressure. It would be underestimated. And if you have a thicker cornea,
Mm-hmm.
your intraocular pressure would be overestimated. So that's the
Okay.
reason you need, to measure the corneal thickness, which we do it by a pachymeter, and it's called pachymetry.
Mm-hmm.
Uh, the second one, gonioscopy, is, for us glaucoma people, the most important test for
Okay.
a glaucoma person, because gonioscopy actually decides what is the kind of treatment that you're going to be given.
Mm-hmm.
Gonioscopy is basically, to explain in a very simple language, is the eye has 2 compartments, a compartment at the back, which we call the posterior chamber, and a compartment in front, which we call the anterior chamber. And the two, as we explain to our patients, are connected by something like a bridge. So
Okay.
what happens when the bridge is narrow, the amount of fluid which flows, which is the aqueous humor, we call, it's a fluid inside the eye. It flows from the posterior part of the eye, posterior chamber, into the anterior chamber and out into our body. and that's through that bridge. And if the bridge
Okay.
is narrow, then the fluid that flows in a given point of time is not enough.
Okay.
There's a stagnation of fluid. And once there's stagnation, the intraocular pressure rises. So a very uh, logical simile would be that if you actually open the tap in a basin
Mm-hmm.
and you close the outlet pipe, so the water
Mm-hmm.
collects in the basin and that would create a pressure. So that's exactly how it is.
Okay.
And once you do this gonioscopy, you're in a position to know whether you actually need to clear that pathway, that bridge,
Mm-hmm.
or if that pathway is clear, then you don't have to do anything to clear the bridge. All you need to do is start the patient on medication if he or she requires. So
Okay.
this actually divides glaucoma into the two major uh, subsections, which are primary open angle glaucoma and primary angle closure disease. So if that bridge
Okay.
is narrow, the person falls into the primary angle closure disease, which
Mm-hmm.
would require, in most cases, a laser treatment, following which medication will work. And if it's the primary open angle glaucoma, then you do not have to do any laser treatment. You can directly start off with medication. So
Thank
that's the reason
you.
gonioscopy is very
Mm.
important and the deciding factor for starting treatment.
Okay. So again, I'm just going to a side this thing. So this list of tests. Now, all ophthalmologists would definitely, so all eye specialists will definitely be aware of this. So I'm coming to where they should go for the testing. So now let's test number 3, optic disc evaluations. Will you just briefly describe what this is?
Yeah, so the optic disc evaluation is more for the ophthalmologist than for the patient,
Mm-hmm.
because optic disc evaluation actually gives a good idea to your doctor that how much the disease has progressed. That's
Mm-hmm.
basically optic disc evaluation.
Mm-hmm.
And next is the visual fields. Visual fields we briefly spoke about when we spoke about
Yeah.
the peripheral field of vision. So these are tests where your peripheral field of vision is tested,
Mm-hmm.
and we can actually find out from this test that whether you're losing peripheral vision.
Okay.
So, but again, a word of caution here is that fields generally deteriorate when the disease has progressed, because
Mm-hmm.
early in the disease, the fields generally do not deteriorate. And since it's a functional test,
Mm-hmm.
it's, you know, rather difficult to perform maybe at the first attempt. So you need to have 2 or 3 goes before you can actually perform the test where you have a good test reliability.
Okay. So, and again, the other thing is, Chandrima, when you talk about, visual field loss, if the person's, day-to-day life does not involve the use of the peripheral vision a whole lot, then is it like you said, it's very highly likely that they would be missing it, right?
Yes.
And this
Yes.
list of tests, now you are a specialist in glaucoma, but these are tests that you would recommend for anyone. Absolutely, right?
Yes, I would.
Yeah. So next comes the optical coherence tomography.
Yeah. So the optical coherence tomography, to give you a good simile, is say it's an MRI, the
Mm-hmm.
magnetic resonance imaging that we have for the other parts of the body, but
Mm-hmm.
the MRI can actually dissect and take a picture of your body at about 50 microns, but
Mm-hmm.
the optical coherence tomography can actually dissect your eye and take a picture at 2 microns. So it's
Wow.
a highly specialized
So
test.
I'm
Yes.
just going to explain a little bit about, because many people may not be aware of what the slicing Chandrima is talking about. This is not the actual slicing. So this is an instrument which slices in terms of image. So she's talking about 2 microns. That is like, so Chandrima, if you were to give a comparison between a hair, like how thick is like a scalp hair?
Well, a scalp hair is, I think, about what, 5 microns?
Yeah, so you can imagine the thickness of 2 microns is the image. So that is how it artificially slices. So basically, bottom line is if there is some problem, it will not be missed, right, Chandrima?
Correct, correct,
Yeah.
absolutely correct.
So, okay, then the next optical coherence
And
tomography.
I'll just say another thing about it is that this is actually the earliest test which can detect glaucoma.
Okay,
And it is when this detects glaucoma, we actually call it pre-perimetric glaucoma. Visual
okay.
fields are called perimetry in our medical terms.
Yes, I
So
remember
optical
that.
coherence tomography actually detects pre-perimetric glaucoma, or glaucomatous patient, when he or she progresses, that is also when the optical coherence tomography can detect the progression earlier than the visual field scan.
Mhm.
So it's basically early in the disease or disease progression that we use the optical coherence tomography.
Okay. And the last one.
The last one is the stereoscopic disc photography. So the basic thing, this is related to the optic disc evaluation, which is there in number 3. So what happens is that, say I am one glaucoma expert and Shabnam is the other glaucoma expert. So a patient comes to me and I see the patient, and I basically write down that in the optic disc evaluation, that the cup disc ratio is 0.5 or 0.6. I write it down that way, and I don't make very many notes there. And then the patient goes to Shabnam, say after uh, a span of a year or two, and she sees the optic disc and sees that I've written zero point 0.5, but there are other things to the optic disc evaluation which I have not written, because maybe in my busy clinic I could just write
Mhm.
that much for myself. More than that was not possible for me to write. So if you have a stereoscopic disc photography, then that photograph the patient carries. So when Shabnam sees the same patient 2 years later or a year later, she'll see the photograph and she'll get a much better idea of what the baseline discs looked like, and
Mhm.
whether they have progressed or not. She would be able to assess by looking at those baseline disc photographs. When she compares it with the disc photograph, or she sees the disc after a year or after a couple of years. So that's the reason, to maintain a baseline, we want to have a stereoscopic disc photography done.
Thank you so much, Chandrima. Now, one thing I want to mention to, for our audience is all the tests that Chandrima has mentioned. Now, your ophthalmologist, the specialist, will know what these tests are. And I can tell you something. So back when we were in India, we call them medical college. Here it's med school. So none of these tests are things that I have come across in my, so when we studied basic ophthalmology in medical college. My point in sharing this is, what happens in India, Chandrima, very often, let us say I've recommended these tests, so they'll go to their relative who's a doctor, but not an ophthalmologist, maybe an internal medicine or, cardiologist or something else. And quite often I've found that, I think it's our ego. I don't know. It's difficult for us to say, I don't know this, that's not my specialty. Quite often they are told, oh, you don't need such detailed testing. Dr. Shabnam just asks for too many tests. But I work in the area of preventive predictive
Yes.
medicine. So I am definitely not looking at, treating illnesses. I would much rather that we prevent them. So that is one thing I wanted to highlight, that your friend or relative may be a very good specialist in another field, but he or she will not know about the eye. And a lot of this is like fairly recent. So another thing is, and these instruments are very sophisticated, Chandrima, what I understand, because I went for an eye checkup here in Calgary, and this was with the optometrist, and I have never had such a detailed eye checkup before. And I used to work in multi-specialty hospitals in Mumbai, and it's like she's told me, okay, Shabnam, I'm going to show you, this is how thick your cornea is, this is how your retina looks, this is how this is how that. And I thought, oh, I missed out on a lot of like good eye checkup in India then. So Chandrima, where would someone, let us say I decide that I want to have a good evaluation of my eye done. So where would be one place where they would find everything together? Or would they have to go to
So
multiple places?
yeah, so it's best to go to a tertiary eye care center.
Mm-hmm.
And if on a preliminary examination you are detected to have glaucoma, then it's
Mm-hmm.
best to see a glaucoma expert. because
Hmm.
even ophthalmologists, you were talking about general medical specialists of other subspecialties, but even ophthalmologists who are not glaucoma experts actually miss out on gonioscopy. They think
Hmm.
that it's another, say, 5 minutes wasted, so let me move on with my next patient. You know how it's
Okay.
like. So even ophthalmologists miss out on gonioscopy, even though
Hmm.
it's such an important test for glaucoma. So the
Hmm.
best thing is to go to a glaucoma expert at least once, so that you know what's happening actually,
Yeah.
and yeah, you can actually take it on from there.
So if everything is normal, is like a yearly detailed eye checkup like this okay, or does the interval have to be shorter?
No, I think a yearly checkup is fine, unless
Hmm.
you actually have a problem. Otherwise, a
Yeah,
routine
that's a
checkup,
different story. Yeah.
annual checkup is fine. Yeah,
Mhm.
yeah,
Thank you, Chandrima. So now we're just shifting gears a little bit and going into, I know, diabetic retinopathy is not your area of specialty, but this is a message that is missed so often. And because you have a specialty center, so of course you know what it. So people who with diabetes, how often should they have an eye checkup? Number one. Number two, what is it that we are talking about when we talk about diabetic retinopathy? Because a lot of people, I'm shocked at how many people who have diabetes, they don't know what are the other organs that can be affected by because of diabetes, particularly when it's uncontrolled. So Chandrima, will you just explain a little bit about
yeah,
what people with diabetes should be aware of? And I'm talking about both type 1 and type 2, though type 2 is the more
yeah,
common.
yeah. So diabetics should have an eye checkup definitely the moment they're diagnosed as having diabetes. And once they're labeled as diabetics, then definitely a yearly eye checkup is advised,
Hmm.
unless they have diabetic retinopathy,
Hmm.
which would require more frequent checkups.
Hmm.
And diabetic retinopathy actually progresses slowly in some people, but it
Hmm.
also does progress very rapidly in certain people. And
Hmm.
the key here is good control of the diabetic
Yeah.
status. Fluctuation of blood sugar levels actually affects the eye in the worst way possible.
Hmm.
And there are basically two different types of diabetic retinopathy. One is the proliferative diabetic retinopathy, which is the more serious type, and there's the non proliferative diabetic retinopathy. Proliferative diabetic retinopathy actually results in vitreous hemorrhage and a complete loss of vision at times, though of course you can regain vision once the
Hmm.
hemorrhage clears up. But
Hmm.
that's a uh, difficult stage of the disease.
Hmm.
And non-proliferative diabetic retinopathy is the more earlier form of diabetic retinopathy. But in both the forms, you need to have your eye checkup done as frequently as your ophthalmologist would advise you,
Hmm.
because sometimes we see, say, certain microaneurysms in the vessels,
Hmm.
and we want to observe. So we ask the patient to come back, or we do a digital angiography where we can actually, see the leaking dye in the vessels, and we actually laser those areas from where the dye is leaking. So
Hmm.
it's very important that once one is diagnosed with diabetes, he or she consults an ophthalmologist and then follows the ophthalmologist's advice quite
Hmm.
religiously.
Actually, yeah, when you say once a year they need a checkup, I recommend my patients, because many of them don't have their, blood sugars in the optimal range. So another thing is, if your blood sugar is not well maintained, it's not in the normal range, then some of you will probably need every 6 months also, because the key is your blood sugar control. So if you are someone who has diabetes and your blood sugar is not normal, is not in the range, then you do need to go. And it's like, here what happens in India is very often people will not go to the doctor because they don't have a problem. So this is to preempt that problem, number one. Number two, of course, given the COVID situation, it's different. But even when there was no COVID, quite often I'd find that people with diabetes haven't even had their yearly, fundoscopy done. So when we say fundoscopy, it means that instrument, which is, the ophthalmologist comes near to your eye and checks the back of the eye. So sort of that is the retina. Now, Chandrima, one thing I wanted to ask, because, medicine has advanced so much. So back in our college days, we needed that eye drop to, dilate our pupil. So that means your eyes become big and you can't focus. Is that necessary for fundoscopy now, or have things changed?
Yeah, things have changed. Fundoscopy is a very broad term, basically.
Mhm.
So, say like a person like me, a glaucoma person, I see the disc
Okay.
at the slit lamp. I don't use the direct ophthalmoscope, which we used to use in our MBBS
Yes.
days.
Yeah.
That's almost a museum instrument now.
Oh, good luck.
So we don't use that. So we use a high plus lens, a plus 60 or a plus 78 or a plus 90 at the slit lamp to see the disc.
Yeah.
And for me, that is sufficient, because with that I can see the disc and the macula.
Okay.
But for a retina specialist, he or she needs to use the indirect ophthalmoscope,
Okay.
where they wear something like a headband,
Okay.
and they hold again a high plus lens, a plus 20 diopter lens close to the eye, and
Mhm.
they see the periphery. That's where you can see the ora serrata and stuff like that.
Okay.
So it depends on what you actually want to see.
Mhm.
What instrument you use depends on that, actually. So I can do everything at the slit lamp,
Yeah.
but a retina specialist has to get up from his or her chair and do an indirect ophthalmoscopy to see the periphery of the retina for holes and lattice degeneration and stuff like that, or retinal detachment for that matter.
Mhm.
So that's how it is. And as I told you, the ophthalmoscope is like, nicely kept, honored in the museum.
That's
The direct
great to know,
ophthalmoscope.
because I remember years ago when I was an OBGY, the day I had an appointment scheduled for my eye checkup, because that, the effect stays for so long that I cannot focus on near stuff. I would have to ask one of my colleagues to be a backup if I had a delivery, because I wouldn't be able to do any suturing. So I'm so
Yes,
happy to
yes.
know that that has, moved away, that you don't, and
No,
that
we
you still
still
do.
dilate the pupil when the retina expert sees it. Yeah, because
Okay.
the periphery can't be seen otherwise. To see
Okay.
the aura, we dilate it, but for
Okay.
a person like me, we don't need to dilate.
So again, that would not be a routine test for, most people who do not
Yes,
have a problem with the retina, right?
yes,
And are
yes,
there short
yes.
acting?
And the other thing is, thank God,
Sorry, go ahead.
thank God for COVID. Thank God we don't use the direct ophthalmoscope. Otherwise, we'd never
Yeah,
be able to do
because
that
that's like
test now
very
anymore.
close
So yeah,
proximity. Yeah.
yeah, very close up. Yeah.
And have the medications changed to like a relatively short acting ones, where the pupil doesn't have to be dilated
Yes,
long?
it's just yes.
Okay.
Yeah, the pupil dilates in about 15 to 20 minutes,
Mhm.
and the effect stays maximum for, say, about 3 to 4 hours maximum.
Oh, okay. So it's
Yeah.
still 3 to 4
It's
hours.
no longer atropine. Yeah, it's no longer atropine.
Yeah.
Yeah.
So
It's
this thing
something
of
called
having a
tropicamide.
backup colleague if you're a surgeon is
Yes.
relevant. And your daily
Yes, yes.
emergency. Sorry, just laughing about stuff, because I remember, those days, and I'd say, I can't see, so I need you to help me with the delivery.
Yes, I know, because it paralyzes your accommodation.
Yeah.
So you cannot see near at all.
Yeah, and the lights also, and while driving as well, I remember
Yes,
it was
yes,
challenging. So
yes,
anyway,
yes.
bottom line is that is not going to be for everyone. That is going to
No.
be for people who already have diagnosed problem with the retina. So obviously that's a different story. That's not everyone.
Yes,
So that was
yes.
one thing, and we are almost at the end of our scheduled time. But as you know, Chandrima, you and I, we are very interested in technological developments, and I call myself a health tech enthusiast. So given the the ongoing pandemic, we know that there are a lot of conversations about how can you monitor at home. So obviously, all the tests that you have described, none of them can be done at home. But recently, there have been some very interesting developments. And again, the thing is, I want to state ahead of time, most of the developments that Chandrima is going to talk about will not be available right, like, at your neighboring, eye care center right now. But it is good to know of what is going to be available in the future, and what are the things we can, look forward to. So Chandrima, will you tell our, audience a little bit about what are the developments coming up, down the pipeline
Yeah, yeah. So we have the portable field analyzer. The visual field analyzer is portable. It's available. So you just wear it like uh, a spectacle, a huge one in front of your eyes, and you can actually perform the test. And then, interestingly, we from the Glaucoma Society of India, we just had a competition where we asked for uh, what are the ways that you could actually uh, ask for compliance in your patient, and how would you deal with glaucoma patients in COVID situation. And
Oh,
there was
wow.
one video which actually won the first prize. Is
Mhm.
excellent. They called it Uberization of eye care.
Oh,
And they
wow.
had this person, health worker on a bike, who would go with a bag, and he would have one of those analyzers. There's a handheld slit lamp, and there's the Perkins tonometer, and there's the stereographic photograph taking instrument. And all these four things would be in his bag. He would go to the house of the patient and do all these tests and
Oh, wow.
come back,
And
and then show the reports to the doctor and get interpreted.
so one
So,
thing I want to stress upon, Chandrima, what you're telling me is this is a healthcare worker who has been trained to use those instruments.
yes,
It is
yes,
not a specialist, not a doctor. So that is
no,
exciting because you can train healthcare workers
yes,
with a bag like that and go to places. This is very exciting, Chandrima. So then
yes.
all that information, now next the processing that happens at the back end, and that is where the specialist comes in. Am I right?
Yeah, absolutely, absolutely. And they even, like right from there, they send the pictures across, and you're sitting in your clinic, and you can actually right there give a diagnosis. That supposing he goes to check, say, the father or the mother for glaucoma, and the son or the daughter is at home and says, "Let me check you as well." And to find out whether he or she is, at risk for glaucoma, you can
Mhm.
see it right there and give them a diagnosis, basically.
Wow, this is so exciting. And I'm sure your Glaucoma Society is planning on how to deploy it all over India. I'm sure you're already working on that.
Yeah, I'm sure we would work in it at
Yeah.
some point of time once we are, over with the pandemic and stuff like that.
Mhm. Now, another interesting paper which came out, I think 5 or 6 years ago, was Google had done this. I think this was actually done in India. So where they were basically, what I am excited about the eye, and I'm not an eye specialist, is so the eye is the only part of the brain that can be seen from the outside without doing like expensive imaging or any invasive test. So invasive test, we mean like not poking you or doing any of that. So that is why the eye is sort of like a it's a what do you call it, this thing of the brain. So what was exciting about that Google study was when they looked at people's, and Chandrama is going to explain a little bit more about it, when they looked at people's eyes, and this was again not a specialist checking them, right? This was a healthcare worker with a fundus camera, was it? So what they
Yeah.
found is they could predict, conditions like heart disease, stroke, so cardiovascular disease, 5 years before people actually had symptoms. So Chanima, will you tell us a little bit about that study and how can that be, sort of translated? And again, both of us are just, you know, we are just visualizing what is possible. A lot of this is not available all over India right now today, but hopefully it will be. So Chanima, what did they exactly do, and like what was so exciting about that particular study?
The first thing, the whole thing, very exciting about it is that, the only place where you can actually visualize the central nervous system is the
Mhm.
eye.
Yeah.
And what we were talking about is the optic disc evaluation,
Mhm.
which was number 4, I think, on that list. So when we are doing optic disc evaluation, we actually are looking at the retina, and the retina is a part of the nervous system.
Mhm.
So in the retina, you have vessels, you have arteries, you have veins, and you see the blood supply, how the blood is flowing. So once you see that, you can actually predict a lot of things. Like even before this study, if someone had a central retinal artery occlusion, we would immediately ask that patient to have a full cardiovascular checkup, because somewhere something is definitely going wrong for the retinal artery to get occluded. So similarly, when you see the fundus, and you can actually measure the blood flow that is going on in the veins, so you can see the perfusion pressure. So all these things are actually indicators of what your general health is and where you need to actually have a checkup.
Yeah.
So
The
it's
eye
very
is
fascinating.
window to your brain, and not just to your brain, because I always talk about brain health is not independent of heart health. So they are all together. Now, the other thing, Chandrima, is because in countries like India, cost is such a major factor. And I know many of your colleagues have come up with some interesting, we call them the jugaad, Indian jugaad. Like, so jugaad is a term which someone has, a journalist has described it very well as, so the Indian way of trying to customize things with material that is available nearby right then and there, rather than wait for some technological development, which might be very expensive initially. So Chandrima, what are some of the developments happening in India in that relation? And I know I'm putting you under the bus because that is not your area.
No, but a lot of developments is true are going on, and they try to actually, like, say, the retinal, the glaucoma shunt, the glaucoma filtration device that we use. The
Okay.
Bavald is the one which I saw them using at Moorfields, and we had a valve. We didn't have a shunt, but the Arvind Eye Care System has come out with the ADI, the aqueous drainage device,
Oh,
which
wow.
is like indigenous, and a Barwal would cost anyway in Indian money about 20,000 rupees, whereas the Adi costs just 3,000, 3,500 rupees. So that's where, a lot of development is taking place. And similarly, we talk a lot now about MIGS, that is minimally invasive glaucoma surgery.
Oh,
so
wow.
there also the expensive things which are there, like the trabectome or the eye stent, and these are being actually copied in India, and indigenous things are on the way. So maybe there would be a lot of indigenous things in the next 5 years or so. That's being optimistic, of course, but I'm sure if not everything, at least some of it will be there, definitely. Yeah.
That is so encouraging. So what Chandrima was describing about minimally invasive, surgery is, most of you are familiar with laparoscopy, for example. So what laparoscopy did for, let us say, gallbladder removal. Now, I think laparoscopic cholecystectomy is so common all over India now. I don't think anyone has an open, gallbladder removal anymore. Likewise,
Yes.
my primary field of OBGY, so not obstetrics, gynecology, and laparoscopy has been around for a long time. So this is essentially, in very simple terms, Chandrima, this is laparoscopy of the eyes. This is what
Correct. Absolutely.
and
Yeah,
the
absolutely. It is.
advantages would, so what are the advantages? Like, is it, yes, in laparoscopy, in gynec surgery, I know pain was so much less in women who had a laparoscopic surgery versus open surgery. So in ophthalmology, in your glaucoma surgery, what would be the advantages? And the next question is there a steep learning curve? Because again, next problem comes, how will people access such services?
Yeah. So in ophthalmology, the biggest factor here would be, back to work,
Oh, okay.
back to work the next day.
Mhm.
Yes. So that is it basically. Like we have the femtolaser. The
Mhm.
cataract surgeries that they do at our place now is all with femtolaser.
Mhm.
So there's basically, there's no cutting. It's through
Mhm.
a laser that you enter and you do your surgery and come out. So say if with a femtolaser, we can do a trabectome or a eye stent or something. So with that same delivery system, we can actually implant an eye stent or a trabectome there, or ablate the trabecular meshwork for that. And the patient has a full recovery the next day. The patient goes back the next day. Otherwise, at this moment, when we do a device, we implant a device, or we even do the gold standard for glaucoma surgery, that is trabeculectomy, the patient has to at least rest for 7 to 10 days.
Okay.
But that would be totally like gone, it would
Wow.
really be back to work the next day. Yeah.
That's fantastic. Like, this is This is amazing. So
Yeah.
essentially the effects are similar in, that's also interesting to know that laparoscopy made so much of a difference to the patient's life. If they could go back home
Yes.
in a second day or maybe even that day, if the surgery was early in the morning. So it's similarly
Yes.
happening in eye. Now, Chandrima,
Yeah.
the last this thing, what would be your, few messages for people who, like, what is it you would want people to know? Like, you see a lot of patients who come with very advanced glaucoma. So what is it you wish they knew before, so that they didn't have to lose their vision and go through all those problems?
Yeah. So here I would actually bring in the Hubli River glaucoma study,
Mhm.
where we did the study as the largest glaucoma prevalence study published till date.
Wow.
And there are three parts of it.
Mhm.
Yeah, there are three parts of it. One is the main study, the other is the angle closure study, and the third is the primary open angle study. So while doing the study has actually two arms. There's a rural arm and a urban arm. The urban arm was done at our place, and the rural arm was done at a tertiary center that we have
Okay.
about 2.5 hours from Kolkata.
Mhm.
And what we discovered when we did this study was that uh, 90 almost 95% of the people were unaware that they had glaucoma,
Oh.
because we did a door-to-door survey.
Mhm.
And the other thing which we realized, that those who did come for treatment came very late in the disease,
Mhm.
so we could not stop them from losing vision. So what the message that I would like to put across is that glaucoma is a silent blinding disease. The earlier that is detected and you are treated for it, you could actually prevent your visual loss, because
Mhm.
early in the disease, even if there is very little visual loss at the periphery, you would not even feel it in your day-to-day life. So get yourself tested for glaucoma. If you have a sibling or your parents with glaucoma, a family member with glaucoma, or if you're wearing high plus or minus power, eye injury, that's when you should see a doctor and get your eyes checked for glaucoma. Glaucoma, we can prevent visual loss if you come early in the disease.
Mhm.
And what goes, we cannot bring it back, but what remains, we can actually preserve that.
Mhm. Thank you so much, Chandrima. This has been like so educating, and I am sure our audience will also benefit from this. So, Chandrima, what is the best way of, if someone were to reach out to you or would like to, visit your eye center? What is the best way of getting hold of you?
Yeah, so my email address is there,
Hmm. Okay, I'll post the.
drchandrimapol@gmail.com.
Yeah.
Yeah, that is there. And we have our website, www.bbi.in. So
Okay,
if you go
I'll
there, you
post that.
can, anyone can book an appointment and get across to me. So that is it. And at the moment, I'm the secretary of the Glaucoma Society of India. So you can also reach me through the Glaucoma Society website
Okay.
for these 2 years. Yeah.
Thank you so much, Charima, and thank you very much for investing your time with us today. And bye now.